Thank you very much. I want to begin saying thank you, Alberto, for organizing this session. And thank you for inviting me, of course. I have no disclosure. Just some slides for people that are not familiar with this disease. I want to remember you that rheumatoid arthritis is a chronic systemic inflammatory disease that affects synovial joints. And it induces a symmetrical polyarthritis that is simultaneously with cartilage degradation and bone erosions. It has also different systemic, it gives rise to different systemic alterations. Then, of course, they have decreased in the last decade, but they are still important for the prognosis of the disease. In spite of the high advantage in the research about this disease, we do know now the exact reason for the onset of the disease. It has been postulated that some environmental factors such as trauma, virus, or smoking, together with the presence of genes of susceptibility and in epigenetically modified individuals. This group of alteration triggers an autoimmune response that lost the tolerance. The breach of the tolerance is in fact the reason for the increase in the synovial inflammation that is asymptomatic in the first process, and then the increase in cytokine concentration and the increase in the synovial inflammation destroys the joint. And there's not only the synovial tissue, but also the cartilage and the bone. And of course, causes an increase in other comorbidities. This is really a clinically heterogeneous disease coexisting rapidly and slowly progressive phenotypes. The different clinical manifestations for the diagnosis are clear. Although the presence of different biomarkers such as rheumatoid factors or ACPAs are reliable markers, but not during all the process. They are less specific in the early disease. And as you know, some individuals with RA never develop antibodies. Indeed, beyond these markers, these blood markers or repertoire for blood biomarkers to assist with diagnosis and with the markers of disease progression or response to therapy, this is currently extremely limited. So probably we need another type of markers, and the synovial tissue seems to be a good candidate to look for that markers. In fact, the synovium is the main tissue affected during rheumatoid arthritis. And not only because synovial inflammation parallels joint destruction and cartilage degradation, but also it's important to know that sometimes the increase in joint destruction and in erosion does not match exactly with markers of blood activity. Macroscopically, the synovium of rheumatoid arthritic patients look like that, an increase in the villi. And microscopically, we can see this villi, as you can see here in the picture. Microscopically, a healthy synovium the appearance is more or less like that. You can see a lining layer with only 2 or 3 cells thickness, consistently mainly in macrophages and synovial fibroblasts, and a sublining mainly consisting on adipocytes with a scarce number of macrophages or fibroblasts. It's really a connective tissue, highly vascularized. And when we look at the tissue in rheumatoid arthritic patients, we can see hypertrophy of the lining layer with a significant increase in the number of cells, and also a destruction of the sublining of the stroma with accumulation of infiltrating cells. You can see here in some examples. There are macrophages, B and T cells, dendritic cells, neutrophils, etc. And of course, this is a typical image of macrophage infiltration, mainly in the sublining. And there is also a clear increase in the neoangiogenesis in the presence of new vessels. Apparently, it seems that these alterations are homogeneous for RA patients, but in fact, if you study it in depth, you can see that even the histopathology in these patients is highly heterogeneous. This is a very recent study regarding this heterogeneity. They study a cohort of treatment-naive early RA patients with high disease activity. They obtain a biopsy at baseline and localize and stain the different cells, plasma cells, B, T cells, macrophages, with by immunohistochemistry, and study the localization, the amount of these cells, and the structures that these cells form in the synovial tissue. And as you can see here, there are different patterns of accumulation of these cells in the tissue. These patterns have been were described for different authors some years ago in different cohorts too. And what they define as different histological pathotypes of the synovium, they describe 3 different pathotypes. The lymphomyeloid pathotypes, characterized by a high accumulation of plasma cells, B and T cells, and macrophages, mainly forming this kind of aggregates, of lymphoaggregates. You can see the diffuse myeloid pathotype, where cells, plasma B and T cells are present, poor presence of B cells, but there are also macrophages, but the structures that form these cells are diffuse and not structured as this one in the lymphomyeloid. And the other pathotype was what they call post-immune pathotype, with scarce immune cells, but in patients with a highly active disease. Furthermore, the histopathological pathotype were related with clinical phenotypes in the patients. So the lymphomyeloid pathotype was the highest, this group had the highest level of blood markers and a worse erosion grade, while the pauci-immune groups had the lowest levels of activation in the blood, and despite a very active disease. These pathotypes have not only been described in early RA patients, but also in other cohorts. You can see here this study in patients with late RA, analyzing biopsies obtained by synoviectomy or during the total joint arthroplastia. And these patients were medicated with methotrexate or TNF inhibitors. And they also studied the localization and the amount of different cells, as you can see here, macrophages, proliferation rate, B and T cells, like in the other study. And they established what they call immunologic synovitis score, and a distribution very similar to that one described in early RA patients. What they describe is that this immunologic synovitis score perfectly matches with the clinical activity of these patients. They group the patients in responders, low, moderate, or high activity, and the synovitis correlate with the disease activity in these patients with advanced RA that were medicated with different drugs. In fact, this correlation with the presence of macrophages in the sublining have been, this marker was described earlier in different papers. And this another authors purpose that this immunologic score, this histologic score, could be a better marker of disease activity in different stages of the disease, and that it's possible to use this marker as a marker of activity with a better description to only the study of clinical or blood markers. This description of different pathotypes was simultaneously with the description of genetic pathotypes that are in perfect accordance with the histological alterations. As you can see here, in the study of early arthritis that I described earlier, investigators also analyzed hundreds of genes, and they grouped the genes in different groups depending on the pathway or the family corresponding to each gene in lymphoid, myeloid, or fibroid-associated genes. And as you can see here, the different genetics score perfectly matches with the pathotype established by the immunohistochemical studies, especially when you look at the lymphoid pathotype or the fibroid pathotype. Can we get some information regarding the prognostic of the patients with this info of the histological or the gene expression pathotypes? Where in this work, the same group, they study the evolution of the radiographic progression of these patients after treatment, 12 months after the therapy initiation, and they observed that the higher progressors were those described at baseline as lymphomyeloid patients, both by histology technique and also in the gene expression studies. Even in this patient of the lymphomyeloid pathotype that were more intensively treated, the evolution of the disease was worse, the radiographic progression was worse if they have a lymphomyeloid pathotype after the beginning. So, of course, we can get some information regarding the progression of the disease, but what about the studies regarding the prediction of response? So there are limited works at this moment talking about this topic. In general, there are works with a limited numbers of samples and very, very different cohorts. But for sure, this is the future for the election of the treatment. Most of these studies have been carried out with TNF inhibitors, as you can see here, and a study with synovial biopsies obtained from patients with active rheumatoid arthritis prior to infliximab treatment. And what they tried to study is if the presence of an increase in TNF presence, or TNF synthesis, or in the cells responsible for TNF synthesis, if this marker was a predictor of a higher response to an TNF inhibitor. And as you can see here, the responders have a higher presence of this pathway in the synovial tissue at baseline, while the presence of other pro-inflammatory cytokines was not different between responders and non-responders. On the other hand, these researchers look for or found some predictors of non-response to infliximab or to a TNF inhibitor. They studied 25 synovial biopsies obtained from patients resistant to synthetic DMARD that were treated with a TNF inhibitor during 12 weeks. And they study the gene expression of a high amount of cells. What they found is that there are some genes, a big amount of genes, that were increased in non-responder patients. These studies of gene expression were also repeated in immunohistochemical studies, and as you can see here, the higher presence of this kind of pro-inflammatory markers correlates with a lower response to the TNF inhibitor. Intriguingly, if you can get an increase in the presence of these mediators if you treat cells with TNF or with TNF plus IL-1, for example. But the presence of these kind of mediators was not a good response marker, but a non-response marker. And this concept, assuming the limitation of this study, puts on the table a very attractive issue, what is, if you think that probably the better drug for a patient is that one blocking a specific pathway that is increasing this patient. Not always the answer is yes. For example, for a B-cell antagonism, the treatment with rituximab only partially decreases the presence of these cells in the synovial tissue. Furthermore, the depletion of B cells not strongly correlate with the clinical response of these patients. So the study searched for additional markers in synovial tissue for response to rituximab. What they studied were biopsies in TNF refractory, anti-TNF refractory patients and that were treated with rituximab and were biopsied at baseline and then re-biopsied after 3 months. And they choose those genes that have a higher change in the expression between baseline and month 3. And with the expression of these genes, they correlate the change in the expression of these genes with the clinical data of these patients and observe that this correlation was more potent with the advance of the disease with the expression of these special genes. So as a conclusion, it remains unclear whether the synovial pathotyping array does reflect a characteristic of a specific disease or is a dynamic fluctuation due to inflammatory process. However, we have no proof of concept evidence of that the assessment of these histologic studies actually have the potential to predict clinical relevant outcomes. There's, of course, a need to impulse the investigation of tissue biomarkers, employing a higher number of samples, high-throughput technologies, including omics, not only in the tissue, but also in specific cells. And these studies would allow a better understanding of the disease process and guides drug selection. In this end, we will see soon the results of initiatives such as STRAP or R4RA trials, employing this kind of technologies, and also complex data analysis that will for sure improve our knowledge and our understanding of the disease. Thank you very much.